Good morning. Can you hear me?
Good morning, yes.
Okay, we're gonna cover endocrine this morning. Can you guys see the slides?
Yes. Yes.
All right, so first we're gonna talk a little bit about the endocrine glands. These are all throughout the body. They include things like your hypothalamus, your pituitary gland, which they also call your hypophysis. Sometimes when they talk about procedures, they don't use pituitary gland. They use hypophysis. The pineal gland, the two adrenal glands, the thyroid gland, and then you have four parathyroid glands. Those are real tiny. They sit right next to the thyroid. Your thymus, we talked a little bit about your thymus when we talked about immunity. Remember, that's where your T cells are developed. It stops growing when you're about 14, and then it helps your T cells mature. You have the adrenal glands, which sit on top of those kidneys, your pancreas, your ovaries, and your testes. The local hormones are secreted in the digestive tract and they help regulate secretions and motility. Endocrine glands secrete hormones right into the blood. You also have exocrine glands. Those will typically secrete things into a duct, like mucus. We've talked about the hypothalamus multiple times. That's in the brain. I call that your relay gland. So that hypothalamus works with the nervous system and it tells the pituitary gland when to either stop or stop making hormones. It'll also tell the pituitary gland to release certain hormones. Now, you've heard me talk about the pituitary gland. I usually call it the PP gland. And one of the reasons why I call it that is because it controls your PP. So in that gland, you have ADH. ADH is controlling your blood pressure by helping you reabsorb water through the kidneys or by releasing water through the kidneys. So it helps control that fluid balance in the body. Other hormones are growth hormone, prolactin, which helps with breastfeeding, ACTH, which helps with stimulating the adrenal glands so that we can make certain hormones. You have the thyroid stimulating hormone. That's TSH. You'll see it referred to as in most textbooks. And your ACTH is your adrenocorticotropic hormone or corticotropin hormone. That also has to do with stimulating cortisol in the body. You also have production and secretion of those thyroid hormones. That happens from that stimulating thyroid hormone. So we learned about that in class yesterday if you were in the daytime. All right, your colleagues did a little presentation, a little case study on this, and they were telling you about how the thyroid stimulating hormone stimulates T3 and T4. T3 will eventually convert into T4, and that's kind of how it works in the body. And when we talk about those, well, your thyroid is really important for metabolism in the body. So when people don't have a functioning, working thyroid, that can be a problem sometimes. If it's too low, it could actually be life threatening. If it's too high, it can cause a lot of other issues. Also, the thyroid hormones are going to secrete oxytocin, and oxytocin is important both during breastfeeding. It also is important during pregnancy, and sometimes doctors will use medical oxytocin for certain things. You have the luteinizing hormone. I call that the little hoe. Reason why I call it a little hoe is because of what it does. So it helps with estrogen in women by helping produce the egg. In men, I call it the little hose specifically for them because it helps them produce testosterone. So those two things kind of go together, and you'll learn more about that when we get into sexual reproduction. Your pineal gland, that makes your melatonin. So that pineal gland is going to help you get ready for bedtime. The thyroid gland, I'll talk a little bit more about this now. We talked a little bit about it when we were talking about the hormones up there, but the thyroid gland makes the thyroid hormone. That thyroid hormone is controlling your growth and your metabolism. And if it doesn't make enough, we call it hypothyroidism. So everything's going to happen slower. Your heart rate will slow down. You'll become constipated. You'll gain weight. If it's too much, everything's going to go faster. Your heart will go faster. You could have diarrhea. You might lose weight without trying. That thyroid gland is also producing calcitonin. Remember, we talked about calcitonin back when we were talking about bones. That calcitonin helps contribute to bone strength by helping the calcium get into the bone. You have your parathyroid gland, and I told you that sits right next to the thyroid. These are really small glands. They're right behind the thyroid, and they also help with the bone to make it healthy. They control the level of calcium and phosphorus in the bone and in the body. And the parathyroid glands, a lot of times, those will get nicked when someone has thyroid surgery. We might not know about it right away
To the
till their levels get off. Any questions about that?
No.
All right, and then your thymus gland, which makes your T cells that help fight infection. So this is growing. This is part of your immune system developing when you're a child, and then it'll start to shrink after puberty. By that time, you have enough T cells, but it will help mature the T cells in the body. Your adrenal glands, you already know you have your adrenal cortex and your adrenal medulla. One releases epinephrine and norepinephrine, and that is what? Which one?
Fight, flight response. Fight, flight.
Which one? Adrenal medulla helps you release epinephrine,
Medulla.
or okay,
Adrenal
or adrenal
medulla.
cortex, because adrenal cortex helps with the steroids. All right, so these steroids and these epinephrine and norepinephrine, they also affect your metabolism. So you already know epinephrine and norepinephrine can help what? What do they do in the body? Epinephrine and norepinephrine. What do they help with? When they're released, what happens?
Bronchodilation and vasoconstriction.
What's going to happen with your heart rate and your blood pressure?
Heart rate
It's going to
is
increase.
high.
Okay, so you have to remember that. Okay, that's what they're going to do in the body. They're going to increase your heart rate, your blood pressure. That'll help you take in more oxygen. It's going to help with your blood flow. You also have the steroids, okay? So they can help with other things also, your corticosteroids. So they also help with sexual function. So the four things that they help with mainly, but other things: heart rate, oxygen intake, blood flow, and sexual function. Your pancreas. Now your pancreas is going to make insulin. It makes the beta cells there, and the beta cells produce insulin. If you have type 1 diabetes, that's not going to happen. It also makes the hormones glucagon. Okay, so between the insulin and the glucagon, those are maintaining the blood sugar in your bloodstream and making sure your cells get enough energy. If you don't make insulin, like in type 1 diabetes, then the blood sugar levels get dangerously low. I'm sorry, high. Stupid me. High, okay, because the insulin's going to bring the blood sugar down. When we don't have insulin, that's why people develop ketoacidosis, because their blood sugar gets really high and they don't have any insulin to correct it.
So good. Hope I got enough.
Please put yourself on mute. In type 2 diabetes, we make some insulin, but not enough. But the other issue is in type 2 diabetes, usually this happens to people that have a little bit of obesity. So their cells are resistant to the insulin. Then you have your ovaries. The organs will make estrogen and progesterone, and they will help the breasts develop at puberty. It helps regulate the menstrual cycle, and it helps support pregnancy. You have your testes. In men, they make testosterone. That testosterone helps them develop things like facial hair, hair in the groin area around puberty. It also helps the penis to grow, and it plays a role in making sperm. No matter how old you are, stress, infections, or being around certain chemicals can interfere with your endocrine system. Genetics, lifestyle habits can increase your chances of having an endocrine disorder like hypothyroidism, diabetes, or osteoporosis.
Yep, I got one more person in front of you first. Okay.
Guys, I need you to put yourself on mute, please, if you're coming in and out of the lecture. Okay, because we're talking and it interferes with the lecture and the recording. Sorry for the ones that are on here that aren't doing it. I try to tell people every week. Hormones, these are chemical messengers, and they're classified by what action they conduct, by where they come from, or how they're made. So, for example, you have hormones that will affect your blood glucose levels. Things like insulin, glucagon, epinephrine, cortisol, and growth hormone. After they're released from the endocrine gland, these hormones circulate to the target cells where they're going to work at. And those target cells are found in glands or other tissue in the body. They'll act on the receptors in the target cells. The hormones are then metabolized or inactivated by the target tissue or the liver and excreted by the kidneys to prevent excessive amounts from accumulating in the body over a matter of time. When those hormones are released, they're controlled by what we call a negative feedback mechanism, and you have to know about that. Okay, so for example, if your glucose levels increase in the body, like your blood sugar starts to go up, then your body's going to release insulin and try to bring the blood sugar back down to a normal level. Okay, so this increases the movement of the glucose into the cells and lowers the blood sugar. That's how the insulin works. When the glucose levels decrease, the insulin secretion will stop. So it's considered a negative feedback loop. We'll take a little bit better look at it in a second. Sorry, I should be on this slide. We'll take a little bit better look at it in a second. Peptide or steroid hormones. Steroid hormones like estrogen, these are made out of lipids. Non-steroid hormones are made from amino acids. So that's why you have to have a certain amount of these things in your body. The peptide hormones are part of a polypeptide chain, and then those polypeptide chains eventually become amino acids. I'm sure you're learning a little bit about those amino acids. those polypeptide chains. You should be learning about those in nutrition. Are you? If you want to talk, you can press the space bar and talk and let it go, and it'll go back on mute. Are you learning about amino acids in nutrition?
Yes, we learned about them in first term.
Okay. Steroid hormones like estrogen, these are made of lipids, they're fat soluble, and they can move across the cell's membrane because the membrane is also made out of lipids. Once they get in the cell, the steroid is able to move in and connect with those proteins in the cytoplasm. The steroid hormones and the receptor form a complex called a steroid complex. And this will help move it into the nucleus where it influences the expression of the genes. Examples of steroid hormones are cortisol, and that's released by those adrenal glands. Also, your sex hormones, which are secreted by your gonads. The non-steroid hormones are made from those amino acids, and they're not fat soluble. So they're not able to move across the membrane of the target cell. So it has to bind to the protein on the cell membrane. The enzyme will then stimulate another molecule that will influence what goes on inside that cell. Most endocrine hormones are going to be non-steroid. These are things like glucagon and insulin, and they're both produced by the pancreas. Peptide hormones are short polypeptide chains like ADH or antidiuretic hormone and oxytocin, which are produced in the brain and then released into the blood in the posterior pituitary gland. This also includes small proteins like your growth hormone and large glycoproteins like your follicle stimulating hormone produced by the pituitary gland. Now, follicle stimulating hormone, I call that fish. And reason why, because it helps with the sperm, it helps them to move or sort of swim up to the vas deferens where they're stored at. And it helps me remember. When I use the word fish, it helps me remember I'm talking about follicle stimulating hormone. You know, you got to use what works for you. My brain's weird, so little things connect with it, and that's how I remember. But if I give you a mnemonic or if I give you a tip and it's not working for you, if it's not sticking, because sometimes it might not if you don't understand the concept, or I know sometimes you guys struggle with terms that I might use because if English is not your first language, that term might not be common to you. So if what I'm saying to you doesn't make it stick, you got to try to find something that will help it stick. Hormones are chemical messengers that might be classified again by action, source, or chemical structures. Okay, so you're going to have some that are going to affect your blood glucose level. That is going to be things like insulin, glucagon, but also epinephrine, cortisol, growth hormone, and they're going to be secreted, okay, out into the body to do different things. So all these different areas could produce or be a target area for some of these hormones. So you don't have to like memorize all these, okay? But you should have an idea of what is the hormone, how is it working in the body. It is something that you'll eventually need to know. All right? So I remember like the PP gland, that tells me it's posterior pituitary gland. So I know things like ADH are released from that, helping control my water in my body. Also, you have oxytocin coming from there. That's going to help with things like breast milk, lactation, contractions during or after delivery of the baby. So mom will naturally produce these after she delivers the baby, oxytocin, to help the uterus contract. your insulin. Okay, that's being secreted from the pancreas. So it comes from those beta cells. And it helps to bring glucose into the cell. That's a main function of it. So I would know that. And it's going to help lower your blood sugar. So this is why type 1 diabetics can develop extremely high blood sugars, because they need insulin to be injected into the body in some manner. The body's not going to produce it. Sometimes people with type 1 diabetes, we don't know that they have it until later on in life. Like they get a little bit older and they start to have issues. So we don't always know that they have this at birth. Your parathyroid hormone, remember, that's going to increase your calcium levels. Okay? And it helps the body absorb calcium in the digestive tract and the kidneys. Your calcitonin, this helps release calcium from the bone to lower your calcium level. Okay, so parathyroid is going to help increase the calcium level. Calcitonin is going to help decrease the calcium level. Then you have your thyroid, okay? Remember, thyroid stimulating hormone, that stimulates the thyroid gland, and that's responsible for metabolism and growth. Your T3 and your T4, those are what's going to be stimulated. And that's going to help to increase the metabolism. You have aldosterone. You already know that hormone. We've talked about it multiple times. That's helping increase the sodium and the water reabsorption. You know that cortisol is going to help with your inflammatory and your immune response. Norepinephrine and epinephrine. So that's helping with vasoconstriction, norepinephrine. So it's going to increase the blood pressure. Okay. Epinephrine is going to help with your heart rate. It also helps with vasoconstriction and increasing the rate and the contraction of the heart. Any questions on any of those? Now, luteinizing hormone. Why do I call it the little hoe? Look here. It stimulates the eggs in the woman or ovulation, and in man, it stimulates the testosterone. So that's why I use that. It helps me remember. Growth hormone. That's going to help with protein development. Any questions on any of those? And then glycagon. I didn't hit that one. Okay, glycagon helps increase. Okay, it's going to help increase your blood sugar level if it gets too low. So insulin helps lower it. Glycagon helps increase it. So that's why we call it a negative feedback loop, okay? Because as one thing is being released, like as the insulin is being released to decrease the blood sugar, when it starts to get too low, then glucagon will come along and try to maintain it or stabilize it so it doesn't drop too low. The endocrine and the nervous system regulate your metabolic activity. They work on a negative feedback mechanism. They help maintain the blood levels of things like calcium, the hormone levels, and things like PTH, parathyroid hormone, and calcitonin. They have opposing actions on each other. The blood level of glucose is critical to nervous system function and fluid balance. So it's controlled by a bunch of hormones. We just learned about those, right? I just gave you about 5 or 6 that help control that blood sugar. The hypothalamus and the pituitary gland make up a complex system for some of the hormones. Secretion is controlled by more than one mechanism. For example, aldosterone can be regulated by the renin secretion. So we already found that out, right? When we talked about the RAST, when renin is secreted, it causes that angiotensinogen to be produced. And eventually that is also going to trigger that aldosterone. so that the body holds on to more sodium and water, because we don't just need vasoconstriction there, we also need volume if we're bringing up the pressure. Okay, but also aldosterone could be regulated by some other things in the body. When determining the cause of a hormone deficit or excess, we have to check the pituitary hormone levels. So when we're talking about endocrine disorders, the thing is, they're usually going to be either something's too high or something's too low. And the most common cause of a pituitary gland disorder or endocrine disorder is going to be a tumor on that pituitary gland. A lot of times it's benign, but it still can interfere with the function. All right, so let's look at this negative feedback loop. An example is regulation of the calcium levels. So the parathyroid gland will secrete the parathyroid hormone to regulate the calcium level. If the calcium level decreases in the body, then the parathyroid gland will release the hormone in order for the blood calcium to increase. Okay? However, if the calcium level increases too much, then the parathyroid gland needs to reduce that production, okay, so that it doesn't get too hot. Now, calcitonin can also help the body release some of that calcium. So the parathyroid gland is working to release the parathyroid hormone, but then when the levels of the calcium become too high, it'll stop producing that parathyroid hormone or slow it down so that the calcium level doesn't get too high. Here's an example using glucose and insulin. So when you eat a meal, it's going to increase your glucose level, and your glucose level will go above the normal level. So what's your normal level? Most people, we want that blood glucose to stay within 70 and 140, right? Anything above 140 is considered elevated. So you eat the meal, that raises your blood glucose level, and it may go above that 140. And when it does, your pancreas is now going to start to release insulin, because insulin is going to help lower the blood glucose. Remember, if we don't have enough insulin, like in type 1, our blood sugar is just going to continue to go up, because this part won't happen. So the pancreas is releasing insulin into the bloodstream because it recognizes that the blood sugar is getting high, and that will signal the liver to start taking up the excess glucose and store it as glycogen. That causes the blood glucose level to go back down again. On the other side, if you miss a meal, your glucose level will start to go down, and it may drop below that 70. That should cause your pancreas to secrete glucagon into the bloodstream. That's going to signal the liver to start converting the stored glycogen into glucose, and that glucose would then raise your blood level. Any questions on that? You have to know the negative feedback loop. Some of the hormones, like thyroid, are maintained at a constant level. Others might be released in large amounts intermittently as your body needs it. Hormones like estrogen tend to follow a cyclic pattern in women. ACTH and cortisol are secreted in a diurnal matter or pattern, with the highest levels being secreted in the morning and the lowest levels secreted at night. However, if your sleep pattern changes, then the secretion of the hormones would also change with it. Any acute stress can cause the sympathetic nervous system to override the hormone pattern and release additional amounts of things like ACTH and cortisol. So you will have a normal level that's being secreted every day. But if you ran into a super stressful situation, like let's say you're driving to work, somebody pulls out in front of you and you hit them, you're going to see a sudden release of that ACTH and that cortisol because your body's going to go into fight or flight. And that's going to trigger the release of those things. We call the epinephrine and norepinephrine catecholamines. You might see them called catecholamines in some cases, okay? So again, there are two categories of endocrine problems, either too much or not enough of the hormone. The most common cause of an endocrine disorder, and I would know this, is a benign tumor. They call this an adenoma, and it causes excess hormones because the tumor itself is secreting the hormone. Or they can destroy the gland and cause a hormone deficit. So maybe you have something that destroys your adrenal gland, and now you have a hormone deficit, depending on what part of the adrenal gland it destroyed, whether it was the adrenal cortex or the adrenal medulla. We do have people that have destruction to the adrenal cortex, and they develop something called Addison's disease. They have really low levels of cortisols being produced in the body, and it's a really dangerous condition. They have to keep cortisol on them at all times. They might have to get an injection of cortisol if they were placed in a really stressful environment because their body's not able to produce it or not able to produce enough to support that stress situation. In some cases, your target cells will be resistant to the hormone, and that can seem like you have a hormone deficit. A lack of response could be genetics, an autoimmune response, or too much demand on the target cell. An example of receptor insensitivity to insulin is seen in people with type 2 diabetes. Other causes of hormone imbalances are congenital defects in the glands, hyperplasia, so that means overgrowth, okay? Infection, or some sort of abnormal immune reaction or vascular problem. So when we don't have enough of a specific hormone, we got to look at the cause of the deficit or the excess. First, we're going to check our pituitary hormone levels, and we'll check the target glands. For example, if we didn't have enough thyroxine, this could be from a pituitary issue. Maybe the pituitary gland is not secreting enough thyroid stimulating hormone, or it could be a problem in the actual thyroid gland. If it was a problem with the thyroid gland, then the blood levels of thyroid stimulating hormone would be high, but the thyroxine levels would be low. Some causes of that deficit, okay, would be either the tumor is producing too little of the hormone, the tissue receptors aren't working, the antagonist hormone production is increased for some reason, so the hormone that has the opposing effect is increased, and it's wiping out what the other hormone is producing. Malnutrition, not eating proper foods to produce the things that we need in the body. Maybe the gland was removed because of surgery, or it's atrophied because of destruction and congenital defects. So these can all cause deficits of the hormone or a reduced effect. In diabetes, this is caused by not enough insulin. And typically this is caused because of the beta cells. These are located in the islets of Langerhans in the pancreas. But a deficit of insulin also could be caused by insulin resistance. So typically, again, we'll see that in someone with type 2 diabetes that is overweight and they have fat around the cells. And so the insulin is not able to be used the way we would like it to be used. This can lead to abnormal carbohydrate, protein, and fat metabolism because the transport of glucose and amino acids into the cell is impaired. Remember, insulin is going to help bring those things into the cell, specifically glucose, but also amino acids. So that can also interfere with the protein synthesis and glycogen synthesis. Some of the cells are not affected directly because they don't have enough insulin. For example, in the brain, we don't need insulin to get glucose into the brain. That's a good thing because your brain cells or your neurons require glucose constantly for energy. So it's good that the brain doesn't require the insulin in order to get the glucose. In the digestive tract, insulin is also not required for glucose absorption. So when you exercise, the skeletal muscle can use glucose without the proportionate amounts of insulin. That's important because if someone is engaging in excessive exercise, it can deplete their blood glucose and cause them to become hypoglycemic. So this is why if someone is an insulin-dependent diabetic, and let's say they're trying to lose weight and they're going out for things like a bike ride, and maybe they gave themselves their insulin, okay, right before they left. If they're riding that bike and they're exercising, that can cause the blood sugar to drop in addition to the results of whatever that insulin is going to do. So, it's important because you would want to make sure that they know they should have a snack with them or eat a snack before they go, one of the two things, so that their blood sugar doesn't drop too much. Sometimes when your blood sugar drops, you're not aware of it, and you can become very confused, and they could end up in a ditch on the side of the road with hypoglycemia. It might take hours for somebody to find them. Happened to a friend of mine. But he was driving a car. Sometimes the cells are not affected directly because of that insulin again. Okay, so for the brain, we don't need insulin. The neurons can get the glucose without it. And in the digestive tract, we don't need insulin to absorb glucose. The other thing that you should know about exercise is it actually can help control the glucose. So if it brings the glucose levels down, and this is why we would give somebody a snack or make sure that they have something to help them if they're going to exercise in case the blood sugar drops. In someone who chronically has high blood sugars, this could help them control their blood sugar by exercising. So that's why doctors will tell people if they have type 2 diabetes to exercise. There's two basic types of diabetes, type 1 and type 2. Type 1, also known as insulin-dependent diabetes or juvenile diabetes, is the most severe. It happens more often in children or adolescents. It's usually genetic. The deficit of the insulin comes directly from destruction of the pancreatic beta cells because of an autoimmune response. And therefore, these clients are going to need insulin from the outside. We call it exogenous insulin because they don't make any. It is not linked to obesity. The problem is diabetes is a major predisposing factor to things like strokes, heart attacks, peripheral vascular disease. These people can end up with amputations, end up in kidney failure, and losing their eyesight or becoming blind. So the amount of insulin required is equal to whatever your metabolic needs are in the body based on dietary intake and metabolic activity. Complications like hypoglycemia or ketoacidosis are more likely to happen in someone with type 1 diabetes. Okay, so hypoglycemia obviously is the blood sugar dropping excessively, and ketoacidosis is where it gets too high. If the insulin deficit is severe or prolonged, the process continues to develop. And so when they don't have insulin, if they go for a long period of time, they'll likely end up in diabetic ketoacidosis, because if they don't have insulin, or if they're not taking their insulin from the outside, they're not using their insulin pump, they're not taking insulin in the body, they're going to end up with this ketoacidosis. So because the cells don't have any glucose, remember, insulin brings glucose into the cell. In these people, the cells don't have glucose. So the body will start to break down fats and proteins. And this causes an excessive amount of fatty acids, known as ketones or keto acids, in the blood. The liver and other cells are limited in how much lipids or fatty acids or ketones they're able to process. These acids will bind with bicarb in the blood, cause a decrease in the bicarb levels, and a decrease in the pH of the body fluids. These keto acids are then excreted in the urine, and dehydration develops. The glomerular filtration rate in the kidneys will decrease. So the glomerular filtration rate is how we're cleaning that urine, how we're removing things that the body doesn't need and excreting them. But here, okay, the body is not able to do that. It's limited to how much it can excrete. And so this person, if it continues, can end up in decompensated metabolic acidosis, a diabetic coma, and they can die. In type 2, these are considered non-insulin dependent. So they have some insulin, but either the body's not using enough, not taking in enough, or they're not producing enough, or a combination of both usually. So we have decreased pancreatic beta cell production of insulin, increased resistance by the body to the insulin, and an increased production of glucose by the liver, or a combination. Type 2 is a milder form of diabetes. It can develop gradually in older adults that are overweight, but right now we're seeing a huge increase in adolescents and younger adults because they have metabolic syndrome. Metabolic syndrome is obesity. So they have that Dunlap, the belly done lapped over their pants, that fat stomach. Changes in the heart. They're going to have blood pressure issues, an increase in their lipids, and insulin resistance because of that adipose tissue, which is fatty tissue. It's just a fancy name for saying fatty tissue, adipose. Questions on any of that? We can control type 2, okay, through dietary, use of glucose, exercise, reducing the insulin resistance. So that would be losing weight. Or sometimes they can give them hormones to reduce the insulin resistance. There's specific hormones that they'll give. These hormones won't work on a type 1 diabetic, only type 2. And those hormones can also stimulate the beta cells to produce more insulin in the body. So basically, they're going to have to monitor their blood glucose levels. They would receive specific things there, medication-wise, depending on what the issue is. Again, not enough insulin. The body won't be able to get the glucose into the cells. That will lead to an increase in the blood sugar. That excessive blood sugar or glucose in the blood is going to spill, okay, into the urine. So now we have sugar in the urine. And back in the day, what doctors would do is actually drink the urine. And the urine would be sweet or sugary. Okay, so that's how they would know. The glucose in the urine causes an increase in the osmotic pressure. And because of that osmotic pressure, remember I talked about having those large osmotic particles in the urine, that causes that urine to be expelled in the way of polyuria. So excessive amounts of urine. That causes the person to lose fluid and electrolytes, especially sodium and potassium. So they're going to become dehydrated here. Fluid loss through the urine and high blood glucose levels will also pull water from the other cells. And that dehydration is what's causing that excessive thirst known as polydipsia. Also, your cells aren't getting any nutrition here or not enough. Okay, so that causes something called polyphagia, which is hunger of the cells. All right, so lack of nutrients entering the cells stimulates the appetite, known as polyphagia. As the blood glucose rises, the fluid is significantly lost, the appetite increases. So we see those 3 P's: polyuria, too much urine; polydipsia, excessive thirst; polyphagia, excessive hunger. And then if the insulin deficit continues, the person ends up in DKA. So common signs of all types of diabetes, all types: hunger and fatigue, thirst, polyuria, dry mouth, itchy skin, blurred vision. Any questions on that? Okay, complications could be short-term or long-term. Short-term would be something like hypoglycemia, the blood sugar drops. Chronic would be things like the eye issue. So it's going to affect the retina in the eye. It's going to cause damages to the tissue in the eyes. It'll cause damages to the kidneys, damages to the blood vessels. Okay, so these clients are going to have problems, all right, in the body. Vascular disease. If they can maintain the blood glucose levels and keep them stable. So this is why a lot of doctors recommend the bypass surgery. Not always the best choice in my opinion. You should just try to lose the weight. But some people don't have that strength to do that, so they'll take this get quick rich scheme of bypass surgery. The problem with that is if you don't have the ability to lose the weight and to maintain on your own, this probably isn't going to help you, because as soon as you get the bypass surgery and you get used to it, after a while people just go back to their same old habits. And so the stomach starts to stretch again, and then we start to see issues again. Some people do well. They get the bypass surgery, they continue to lose weight, and that type 2 diabetes goes away. Type 1 diabetes is not going away because that is an autoimmune disorder. The beta cells have been destroyed. They cannot produce insulin. So type 1 diabetic is always going to need insulin. So a lot of things also can lead to fluctuation in the glucose levels. Your diet, alcohol, exercise. If you have an infection, it can increase your blood sugars, vomiting, and then complications again can be either acute or chronic. So we already talked about hypoglycemia. This could be caused by too much insulin, by taking oral hypoglycemic drugs, which causes you to drop your blood sugar. Okay, here's the issue. Some of those oral hypoglycemic drugs are made out of sulfa. So sometimes your people might be on an antibiotic because diabetics have a lot of infections, sometimes UTIs. So for UTIs, we treat those with sulfa drugs. And let's say they're taking a sulfa anti-diabetic. The combination of those two drugs could drop that blood sugar more than it normally does and cause them to become hypoglycemic. So we got to be careful with what they're taking with what. In patients with type 1, it can happen suddenly after exercise, especially if it's strenuous. If they gave themselves too much insulin, if they skipped a meal after they took an insulin. And again, sometimes they can recognize it, but not always because of the way it affects the central nervous system. Sometimes they're not aware of what's happening. You'll see them sometimes standing around if they're hypoglycemic and they'll just be staring off to space. You can put your hand in front of their face and all, and they won't even react to it. So in hypoglycemic shock, we have too much insulin. Okay, that transports the glucose into the cells. They end up with hypoglycemia. Again, central nervous system function is going to be affected here. Okay, so they'll have weakness, confusion, pallor, diaphoresis, tremors. That's going to stimulate the sympathetic nervous system. That's going to cause increased gluconeogenesis. And excess insulin will transport in the glucose into the cells. Okay. If the person eats something here, they can go back to a normal state. If they don't have any glucose intake, then the blood glucose is going to continue to drop. The neurons aren't able to function, and they go into this coma and death. I would know the symptoms of that hypoglycemic shock, okay? So disorientation, and they'll usually have a change in behavior. Usually behavior's bad. They'll become mean. They might try to bite you. They might try to spit. They might call you names. The client may appear impaired. So one of the things I talked about is back in the day, a lot of African American men got locked up because they were hypoglycemic, and the officer just assumed they were drunk, put them in jail. Some of them died in jail because they didn't get the treatment that they needed. Sometimes people will have that drunk appearance when their blood sugar is low, and because they have this fruity smell coming from their breath sometimes. Okay, that can also cause an issue. Anxiety or decreased responsiveness. Decreased blood glucose level. Decreased blood pressure. Increased heart rate. And that central nervous system is going to affect that brain here. So you're going to have a decreased level of consciousness. This is why we give glucose, okay? So now your person is comatose. What are you going to do? You can't give them food. So you may have to give them some other method here. If their consciousness is not fully alert, you're not giving them anything by mouth. So you can't think, oh, I'm going to go get them a glass of orange juice. That's not going to happen. So they have to be fully conscious to give them anything, okay? We don't do treatments. I just want you to be aware of that. With DKA, this happens in people that are type 1. They don't have enough insulin. The test question may ask you how DKA occurs. You have to know this. It comes from insufficient insulin. It causes the blood glucose level to go up. So high blood glucose levels and mobilization of the lipids. It's more common in type 1. And it usually develops over a few days. Sometimes it can come from infection or stress, which puts an increase on the body's demand for insulin. It can also come from an error in dosage. Maybe they didn't give themselves enough insulin, or eating too much food, or blame it on the alcohol. Remember, over-exercise can sometimes cause this as well, because over-exercise can lead to lactic acid. And lactic acid levels build up in the body can also contribute to this. So here's your DKA development here. Okay, so we don't have enough insulin being secreted, or the insulin is not getting to the cells. Again, this is mostly in type 1. That decreased glucose transport occurs. Why? Because you need the insulin to get the glucose in the cell. But they don't have any insulin, so the glucose is not getting into the cell. On the left side, you see they develop hyperglycemia. Okay? Urine that will get high blood sugar levels, called glycosuria, because that high glucose is spilling into the urine. Then they develop those P's, okay? Polyphagia, because the glucose is not getting into the cell. Polyuria, because you have a lot of blood sugar, a lot of large particles of blood there. That's going to cause that osmotic diuresis. Polydipsia, increased thirst. When they lose all that urine, okay, they're losing sodium and potassium as well, so that can cause electrolyte imbalances. They're going to end up with dehydration and ketoacidosis. So here, the body doesn't have the glucose. Glycogenolysis starts and glyconeogenesis. We have lipolysis, which is breaking down. We have ketone bodies being formed. Those lead to lots of acid in the urine and in the body. So you have ketoacidosis, and then you have ketones in the urine. All that's happening at the same time. When you look across that top there, and it says decreased glucose transport into cells. So if you go along each one of those areas, that's what's happening in that stage. And subsequently, when you look at the areas below, then it leads to those other things. So for DKA, symptoms: thirsty because they're dehydrated, rough oral mucosa, warm, dry skin, rapid but weak and thready pulse. Remember, they're in metabolic acidosis and they have electrolyte imbalances, potassium being one of them. Low blood pressure. Again, potassium and sodium are going out in that urine, Both of those can help control the blood pressure. You're also losing lots of urine. So that's going to affect the blood pressure. Eventually, they'll end up with oliguria because the body is dehydrated. So now the body's going to start to compensate for whatever fluid is lost. This chart here, just take a look at it. It's really everything we just talked about, okay? But it just kind of puts it into more of a perspective. It might be too much, okay? So if this is too much for you, go back and look at the simple slides. Don't try to memorize everything on here. The main things you need to know is what's happening in ketoacidosis. No insulin. High blood sugar. High blood sugar makes them lose those fluids, become dehydrated. They have acidosis. Acidosis, you already know, is going to affect the central nervous system. 3 P's: polyphagia, polydipsia, polyuria. You know the body can't get energy from the glucose except for the brain and the oxygen, right? Because, in the stomach or digestive system, because they don't need insulin to help with absorption. But everything else in the body does. So the body is not able to get the glucose into the cell because it lacks insulin. So those are the main things you got to know. Plus that statement I said to you about the ketoacidosis, okay? Which I said DKA comes from not enough insulin. Not enough insulin leads to high blood glucose levels and mobilization of lipids. So then after the person develops ketoacidosis, they'll also develop those rapid, deep respirations known as Kussmaul's, that acetone breath, which could be sweet or a fruity smell. So as you can see, an important thing to remember here is whether the person's in ketoacidosis or hypoglycemia, both of them can cause a decrease in responsiveness. Okay? With acidosis, they're going to have that acetone breath or that fruity breath. Where with hypoglycemia, they're going to be confused, sweaty, tachycardic. Metabolic acidosis will develop here. We'll have a decrease in the bicarb levels, a decrease in the pH. Dehydration will continue. The kidneys become, they lose their ability to be able to compensate here, okay, because of the acid accumulated. pH is going to fall, and again, client will lose consciousness. Because of the electrolyte imbalances of the sodium, the potassium, and the chloride, they can have abdominal cramps, nausea, vomiting, lethargy, and weakness. That's for your ketoacidosis. This is hyperosmolar hypoglycemic non-ketotic coma. I try to just call it HHNK, big word. This happens in type 2 diabetics, and it's going to be a slow onset. Usually happens in an older adult, or once they consume a whole bunch of carbs. So they, for some reason, have this excess day of eating carbs. Sometimes it can happen if they have an infection. But it leads to severe dehydration and electrolyte imbalances. So they'll develop hyperglycemia and dehydration because they don't have enough insulin, but they have a little bit. Okay, that's why they don't develop ketoacidosis. This is type 2 diabetics usually anyway. They will still have the severe dehydration here. And whenever you have dehydration, you're going to have neurological deficits, muscle weakness, difficulty with speech, and abnormal reflexes. Now, problems of not controlling the blood sugar when you don't control it. We'll see changes in small and large arteries. We can see microangiopathy in the kidneys where the little capillaries and arteries are damaged. They become necrotic or thick, hard. They obstruct. That causes diabetic neuropathy, chronic renal failure, and that thickening of those vessels, that membrane there, can cause occlusion or ruptures. Retinopathy, which is a leading cause of blindness. Degeneration of the kidney glomeruli, causing renal failure. And neuropathy. All right, so just some of the things that they can develop from diabetes. The problem is, it's easy to tell people, okay, you just need to eat right and exercise. Like for me, I have no problem staying away from heroin, cocaine, crack, none of that. But food? How many of you have that willpower? Because food is a lot for us. Like that's social engagement. That's a time with the family. Or you want me to eat this diabetic diet, but you're in the kitchen cooking fried chicken and collard greens and everything else for everybody else in the house. So how easy is it for you to walk away from those sodas, from that food that you love, from, I don't care how well you bake a chicken or how well you bake a fish. It's good. Don't get me wrong. But there is no baked chicken that tastes like a fried thigh. When that thigh is cooked well and crispy and got the right seasoning, there ain't no baked chicken out there that can touch it. Who can call me a liar on that?
No one.
All facts.
All right, so macroangiopathy, like atherosclerosis. So what macroangiopathy means is that it's just attacking those larger vessels. And because of those larger vessels being affected, now we got to worry about other things. So like the legs, the feet, the heart. So we see heart attacks, strokes, peripheral vascular disease, obstruction of the arteries, ulcers. We want these clients to check their feet every day because of the neuropathy. It decreases their ability to feel things. So when you see impaired sensation, numbness, tingling, weakness, muscle wasting, that's all happening in their legs and their feet. So it's an important concept to understand because when they go to walk, okay, when you have that neuropathy in your legs and you go to step down, it almost feels kind of numbing. And because of it, you don't always know where your feet are, where your legs are. It causes them to fall. In addition, if they walk around barefoot without like a leather sole on their foot, they can step on stuff. And they might cut their foot or cause a wound on their foot and not even know it. So a big thing for us is make sure if you're a diabetic, especially if you have poorly controlled sugars, is that you're checking the bottom of your feet every day in a mirror, because most of them are overweight and they can't see their feet. Okay, I can't even see half of my belly, let alone my feet, and the feet ain't coming up to where the eyeballs are. So we stick them in a mirror. They can look to see if there's any breakdown or anything occurring. They can also get ulcers on the legs. They can get infections. Those infections can lead to gangrene, and then we end up amputating. And when you amputate people's toes, your toes help you ambulate. So they also help with your balance. Your feet are really essential to your health. If you have bad health in your feet, your body is going to know it. So with the neuropathy, it causes damage to the myelinated fibers. Okay, it can also affect the unmyelinated ones as well. But you know, with those myelinated fibers, that myelination is helping with that nerve conduction. So when that's affected, it's going to affect that. These clients will have infections, a lot of fungal infections. So what you'll see is like in the groin, the armpits, they'll develop these yeast infections. Also for females, vaginal. And then, of course, retinopathy, which we already talked about a little bit. Again, if you look at the vessels here, and remember, I keep telling you, all that sugar in your blood is going to break down the walls of these vessels. That's what's happening. The wall is broken down. And most people don't just have diabetes, okay? A lot of them have high blood pressure as well. So they got a double whammy going on here. All right, that peripheral neuropathy is going to cause impaired sensation. They can't feel it. Numbness, tingling, weakness. The legs also ache. They hurt. Okay? And they give them one of the worst drugs out there, gabapentin. I don't like it. I'm on it now. I got to take a little dose every day, but it's a horrible drug. I wouldn't recommend it for anybody. Then they end up with this diabetic foot ulcer, okay? Now, diabetes isn't the only thing that causes neuropathy. A lot of things can cause neuropathy. Cancer treatments, high blood pressure over time, because those nerves and stuff down there in those legs are being damaged, okay, over time. You're not going to feel it. You're not going to know it's happening until it's happened. Infections more common, more severe, especially in the feet and the legs because of the impairment to the neurological status there and the vessels. Fungal infections, again, in the vagina or orally, urinary tract, and those teeth, okay? People got to get their teeth taken care of. Having those cavities, having those germs, that can lead to a lot of problems. Gingivitis, that's going to be inflammation and infection in the gums. And then periodontitis, where it now spreads and it starts to pull the gum away from the bone and the teeth. And they end up with something called trench mouth. Not a pretty sight. Fungal infections. This one happens to be at the navel area, it looks like. Cataracts. Okay. Now their eyes are being affected. So the lens starts to become opaque, meaning instead of being clear, now it's kind of like a white or a gray in there. And so that's going to cause them to see shadows and halos and things like that. And this is because the glucose isn't being used appropriately. Pregnancy, mom can have complications. This can cause abortions, spontaneous abortions, and the babies are going to be born larger than normal. So we call them macrocytic babies. They're usually really big, like 11 or 12 pounds. Okay, and the babies will have hypoglycemia within those first few hours after they're born. So that's something we really have to monitor the babies for. Again, we already went over all this stuff here. Okay, look at diabetes mellitus. There's an alteration in the ability of the body to use the lipids and the proteins here. Okay, So just overall, it's going to affect you in so many different ways. All right, your parathyroid hormone and calcium. Hypoparathyroidism can be caused by a genital lack of the parathyroid glands. There's 4 of them, remember? Or from surgery, okay? They nip them. This can also happen because of radiation, or certain autoimmune disorders can destroy them. If the parathyroid gland is low or not working correctly, it can cause hypocalcemia or low calcium levels. Now, calcium is going to affect nerve and muscle function, but it does it in 2 different ways. So when you don't have enough calcium, that can cause your cardiac muscle contractions to be weak. In the body, though, it increases the excitability of the nerves. Remember, calcium is used for contractions. So in the body, it can cause contraction of the skeletal muscle or cause excitability. And so what we see is muscle twitching or spasms. They call it tetany. And we usually see it first in the face and the hands. So one of the tests that we'll do is to tap the cheek right in front of the ear. Okay? And it'll quiver or spasm when you touch it. That's called Chavoki's sign. And then you have another one when you do a high blood pressure. Like when you do a blood pressure cuff on somebody, where you'll have muscle spasms also. That's called Trousseau's sign. So I remember Chbosky's because of the CH for the cheek. Trousseau's has to do with the spasms that you'll see when you do a blood pressure on someone. Again, hypocalcemia is going to affect the function of the contraction. It doesn't weaken the skeletal muscle contractions because we have enough calcium stored in the skeletal muscle cells. But with cardiac muscle, we don't store calcium there. So those contractions will be weak right away. But the other ones, it's going to be increased excitability. Okay, so you would see that in the hands and the face first. Also, vitamin D has to be present in order for the body to absorb calcium and metabolize it. So if someone's in kidney failure, they can hold on to phosphate, causing hyperphosphatemia. When we have too much phosphate in the body, it lowers the calcium level because they have a reciprocal relationship. So low calcium levels lead to high phosphate levels. Two endocrine glands help regulate calcium: the thyroid gland and the parathyroid gland. There's 4 parathyroid glands at the back of the thyroid gland, and they secrete the parathyroid hormone. Whenever there's a drop in the calcium levels, the parathyroid gland will produce parathyroid hormone. That causes calcium to be released from the bones. The calcium is then absorbed by the kidneys. The kidney will activate vitamin D, which will help the body absorb the calcium in the intestines. Any changes in the bone, the kidney, or the digestive tract can affect your calcium balance, as well as changes in the calcium or phosphate or parathyroid hormone. So if you're looking at this chart here, okay, you have a low calcium level. The body is going to stimulate the parathyroid hormone to release calcium. Calcium is released from the bone. The reabsorption occurs with the kidneys. that increased reabsorption will then occur because the kidneys will activate it and allow it to be reabsorbed in the intestines, and that will increase that calcium level in the blood. It'll also inhibit secretion of the parathyroid hormone once that calcium level gets to where it needs to be. Okay, so once the calcium level raises up to where it's supposed to be, now the body will start to prevent that parathyroid hormone from being released because we don't want the calcium level to go too low. Questions on that? All right, so here it's just showing you if the calcium level drops too low, parathyroid gland releases the parathyroid hormone. The parathyroid hormone is going to do a few things. So it'll stimulate the osteoclast. Those help release the calcium from the bone. It acts on the kidney. The kidneys will stop releasing calcium in the urine and put more back into circulation. It stimulates the kidney to convert vitamin D into calcitrol. The activated calcitrol acts on the intestines to help absorb more calcium. Vitamin D will also work with the parathyroid hormone to stimulate the release of calcium from the bone and reduce the amount of calcium lost in the urine. Once calcium levels are normal, the body will stop the parathyroid hormone from releasing any more of that hormone, okay? If the calcium level becomes too high, then the thyroid gland is going to release calcitonin. Calcitonin stops the bone from releasing calcium, and it will make the kidneys get rid of more calcium. Hyperparathyroidism can be caused by a adenoma, which is a tumor, a benign tumor, hyperplasia, so overgrowth, paraneoplastic syndrome. Remember, paraneoplastic syndrome is when you have a tumor that's secreting certain hormones. And all these can lead to high calcium levels or hypercalcemia. Now, high calcium is hard to get out of the body. Hypercalcemia can cause the heart contractions to become forceful or increased. The most serious effect of hyperparathyroidism is a fracture. Increased parathyroid hormone or too much parathyroid hormone causes calcium to leave the bone. That causes osteoporosis and weakening of the bone so that it can easily fracture. Hypercalcemia also puts you at risk for kidney stones. So if you've heard my mnemonic for hypercalcium, it's moans, groans, and kidney stones. Because you'll have moans from the constipation, groans from the bone pain, and kidney stones. Calcium metabolism can be modified by things like vitamin D or phosphate levels. For instance, in clients that don't move around or that are immobile, someone that has bone cancer, or someone that has multiple myeloma, hypercalcemia can be present, okay? In people with severe kidney disease, there's a decrease in the vitamin D levels in the body. The kidneys aren't able to activate that vitamin D because they're not working. And you need that vitamin D to absorb calcium and to metabolize it. Kidney failure also can cause us to hold on to phosphate and lead to hyperphosphatemia. So remember, phosphate and calcium have an inverse reaction. So if we have too much phosphate, it's going to lower our calcium levels. So what they'll usually do is they'll give your people that are on dialysis phosphate binders to bring the phosphate levels down. You have to watch, because as the phosphate levels go down, the calcium level is going to go back up. So if the parathyroid hormone is not working properly, and again, this is a good chart. This one's good because it keeps everything in a small perspective here. So if we don't have a properly working parathyroid gland, if it's working hypo, okay, what are we going to see? So it's going to affect the calcium levels, okay? And if it causes the calcium level to go up, then we'll see the examples on the right. If it causes the calcium level to go down, then we'll see the examples on the left. Remember, it doesn't affect the heart and the nervous system the same, so it's going to cause the heart to be weak. Whereas with the nervous system, it's going to increase the excitability of that nervous system. So adenomas are the most common cause of the pituitary disorder. Usually they're benign. What happens is the tumor starts to grow and causes pressure in the skull, because that's where your your pituitary gland is. Okay? So the tumor's on that pituitary gland, it's enlarging, and it causes pressure in the skull, which is going to lead to increased intracranial pressure. So because of the pressure on the brain, we'll see headaches, seizures, drowsiness, that hemaniopsia we talked about during when we were doing the eyes. The effect of the tumor on hormone secretion. So hormone effects of the adenoma depend on what cells in the pituitary gland are involved. For example, if the growth hormone is increased, okay, it's going to make a different change in the body than if prolactin is increased. Tumor cells can secrete an excessive amount of a particular hormone. Sometimes more than one hormone is secreted. In some cases, the adenoma may destroy an area of pituitary cells, causing a deficit of the hormone, like not enough ACTH. Therefore, we'll see a decrease in adrenal cortex activity. Vascular thrombosis and infarction associated with giving birth or other cardiovascular disorders also damage the pituitary and can lead to hypopituitarism. Hypothalamic disorders include tumors or infections. So for that, the main thing I want you to take out of that is the adenoma. That's the primary cause of a pituitary gland disorder. Usually they're benign. If it's growing, it can put pressure in the skull. And it's going to depend on what hormones are being released to how it's going to affect the body. These you have to know. So dwarfism, this is short. And we don't have enough growth hormone. They also call that growth hormone somatotropin. So they may say somatotropin on the test. You got to know that. Or somatotropin releasing hormone. So dwarfism can be caused by a deficit of the growth hormone or the somatotropin or the somatotropin releasing hormone. These people have normal intelligence, normal body proportions, but they have a delay in skeletal maturation and puberty. Gigantism. This is tall statue. So there's a difference between this and acromegaly, and you have to know the difference. With gigantism, they have excess growth hormone before they reach puberty or before the epiphysis fuses. Now remember, the epiphysis is the growth plate. So this is going to happen before that fuses or before puberty. Both. Okay? Before puberty and before the epiphysis fuses. Acromegaly is excess growth hormone in adulthood, and it usually comes from that benign tumor. With acromegaly, they're going to have bones that are broader and heavier. The soft tissue starts to grow, and that causes enlargement in the hands and the feet, a thicker skull, changes in the face. And it can lead to things like carpal tunnel syndrome, arthritis. The growth hormone also affects glucose metabolism and how well insulin works in the body. So these people could develop diabetes, hypertension, and cardiovascular disease. So that's for acromegaly. So remember, gigantism is before puberty and before the growth plate fuses. Acromegaly is adulthood, and it's usually associated with that tumor on the pituitary gland. Gigantism is rare. Again, we have growth hormone hypersecretion. These kids grow really fast and tall. And it happens before the long bone epiphysis fuses. These kids will be unusually tall and they'll have delayed puberty. Acromegaly is a hormone disorder when the pituitary gland produces too much growth hormone as an adult. This causes your bones to increase in size. It can cause changes in the face, in the shape of the face. So these clients have a protruding lower jaw or a weird looking brow, enlarged nose, thick lips, spacing between the teeth. It progresses slowly. So you might not even recognize this until people are a little bit older, or you might see it sometimes when you compare one photo with another. Antidiuretic hormone. So you could have too much or not enough. Diabetes insipidus is when we don't have enough ADH. And because of that, you're losing water, not electrolytes, water, just water. So these people are going to have dilute, large amounts of urine, thirst, leading to dehydration. This is not associated with normal diabetes in any manner. Inappropriate ADH syndrome. This is called syndrome of inappropriate ADH. So usually they'll write it as SIADH. And I say too many letters, too much ADH. So they have too much ADH. This can be from stress or because of some tumor. One of the main causes is bronchiogenic carcinoma or small cell lung cancer. And it's because of the hormones being secreted by the tumor. So with too much ADH, we'll see things like diluted sodium levels, but the urine will be concentrated because they're not putting much out. The body's holding it because the excess ADH or too much ADH, it's antidiuretic, so it's not allowing us to pee. So in diabetes insipidus, we can't stop peeing. In inappropriate ADH, we're not peeing at all or very little. We're holding the fluid That's why the sodium levels are diluted. Everything else will be diluted too. In inappropriate ADH, they can develop hyponatremia because they have too much fluid. It's diluting the sodium level. And so when you think sodium, you should think neuro. That's going to affect them neurologically, causing mental confusion and irritability. The two thyroid hormones, thyroxine and triiodothyronine, are secreted by the thyroid gland in response to hypothalamic pituitary secretion of the thyroid stimulating hormone. So the pituitary gland with the HPA axis is secreting this thyroid stimulating hormone. Disorders here can be because of the pituitary or the thyroid gland itself not working. Sometimes they grow an enlargement on the thyroid gland known as a goiter. Goiters can occur in both hypo and hyperthyroidism. They can become large and they can compress the esophagus and interfere with swallowing or put pressure on the trach. There are different forms of hyperthyroidism with increased T3 and T4 secretion. Graves' disease is an example. Graves' disease occurs more frequently in women over 30, and it's an autoimmune disorder. So in Graves' disease, they're going to have hyperthyroidism. So the hypothalamus will secrete the thyroid hormones, okay? So you have some sort of stimulus like cold or stress. The hypothalamus increases the secretion of the thyroid hormone into the blood. That causes the thyroid stimulating hormone to start to circulate. The thyroid stimulating hormone is going to increase the T3 and the T4 into the blood. That will cause an increase in metabolism. Once the high levels of the T3 and the T4 are there, then they'll start to inhibit the secretion of the thyroid stimulating hormone and the thyroid releasing hormone, which is the TRH. Let me just go back a slide. The activity of that thyroid gland is regulated by the thyroid stimulating hormone. This is also called thyrotropin. And it will trigger the thyroid hormone to be released. In a classic negative feedback loop, elevated levels of thyroid hormones in the bloodstream trigger a drop in the production of the thyroid releasing hormone and the TSH. So when the T3 and T4 are released, if it brings up the levels, it's going to stop these other two things from producing because we don't want to continue to produce these levels and increase. When we have enough, we need to stop it. So in simple terms, the negative feedback loop means that if something increases, the production of whatever is causing the increase will slow down. Now, the thyroid releasing hormone is the master regulator of the thyroid gland, and it helps to secrete those thyroid hormones, thyroxine and triiodothyronine. These hormones control the metabolic rate. So that's your T3 and T4, okay? They control the metabolic rate, which helps generate heat. It helps with your muscle function, your heart rate. So when the thyroid releasing hormone triggers the pituitary gland, then it will release more thyroid stimulating hormone, which would cause the body to release more T3 and T4. The thyroid hormones T3 and T4 are regulated in the same way. When levels of T3 and T4 decrease below the normal state, the hypothalamus would release the thyroid regulating hormone and stimulate the pituitary gland to release the TSH, or the thyroid stimulating hormone, which would then produce more hormones and bring up the blood level. Again, once the levels rise, then the TRH, thyroid releasing hormone, and TSH will be inhibited so that no more T3 and T4 are produced. Now, the thyroid gland itself takes iodine that is in our diet and converts it into T3 and T4. The T3 and the T4 are regulated by the thyroid stimulating hormone. The thyroid stimulating hormone is regulated by the thyroid releasing hormone, and that is secreted by the hypothalamus. So that is how the hypothalamus controls things like metabolism, heat, growth. Any questions on that? There are goiters, okay? Endemic goiters can affect a large amount of people in a specific geographic area. It's a hypothyroid condition that occurs wherever there's low iodine levels in the soil and the food. The iodine is trapped by the thyroid gland and used to synthesize T3 and T4. The T3 is the triiodothythyronine, and thyroxine is the T4. Okay, so the iodine is trapped by the thyroid gland and it's used to synthesize the T3 and the T4. Because there's a lack of iodine, we're going to have a low T3 and T4 level or production. This causes the thyroid stimulating hormone to increase because now it's going to try to produce more T3 and T4. Because they don't have iodine, that can't happen. So it causes this goiter or this hyperplasia or hypertrophy of the thyroid gland to occur. So in some countries, we've been able to get them iodine or iodized salt, and that's been able to help. Goitrogens are foods that have elements that block the production of T3 and T4, but they cause increases in the thyroid stimulating hormone. This thyroid stimulating hormone causes hyperplasia of the thyroid gland and causes the goiter to form whenever people eat these substances in large quantities. These foods include cabbage, turnips, and other related vegetables. Lithium and fluoride can also be goitrogenic. Toxic goiters occur from a hyperthyroid condition or hyperactivity of the thyroid gland because of excess stimulation of the thyroid stimulating hormone. And this produces a large nodular gland. The term goiter is the abnormal enlargement of the thyroid gland itself. It does not mean that the thyroid gland is malfunctioning. The goiter can occur in a gland that's producing too much hormone or in hyperthyroidism, or it can happen in a gland that's producing not enough hormone or hypothyroidism, or a gland that's working properly. A goiter indicates there's a condition that's causing the thyroid to grow abnormally. One of the most common causes of a goiter is iodine deficiency. The primary activity of the thyroid is to concentrate iodine from the blood, and that's what helps us make that thyroid hormone. The body cannot make enough thyroid hormone if it doesn't have enough iodine. So if someone has an iodine deficiency, the thyroid is going to be hypo. The pituitary gland in the brain senses the thyroid hormone level is too low and sends a signal to the thyroid. That signal is called thyroid stimulating hormone. That would stimulate the thyroid to produce the thyroid hormone and grow in size. The abnormal growth produces that goiter. Now, Hashimoto's thyroiditis is also a common cause of goiter formation in the United States. This is an autoimmune condition where the thyroid gland is destroyed by its own immune system. As the thyroid gland becomes damaged, it's not able to make enough of the thyroid hormone. The pituitary gland recognizes that the thyroid has a low level, or it's producing a low level of hormones. So it secretes more TSH, trying to secrete more of those hormones. That causes the thyroid to grow, and that can cause, again, the thyroid to develop a goiter. Another common cause of a goiter is Graves' disease. In this case, the immune system produces a protein called a thyroid stimulating immunoglobulin. As with thyroid stimulating hormone, the thyroid stimulating immunoglobulin stimulates the thyroid gland to enlarge and causes it to produce a goiter. However, the thyroid stimulating immunoglobulin also stimulates the thyroid to make too much thyroid hormone, causing hyperthyroidism. The pituitary senses too much thyroid hormone, so it stops secreting the thyroid stimulating hormone. In spite of the thyroid gland continuing to grow and make the thyroid hormone. So Graves' disease will produce both a goiter and hyperthyroidism. Any questions on any of that? There are various forms of hyperthyroidism with increased T3 and T4 secretion. Graves is one example. Graves occurs more often in women over 30 and is autoimmune. It's manifested by hypermetabolism, that goiter, that toxic goiter, and exophthalmos, which is where the eyeballs become sort of bulging and buggy. With the who's the lady in the wheelchair now? She was an alcoholic, they said, and Wendy Williams. If you look at her eyes, she has this. Okay. Exophthalmos is evident. Thyrotoxic crisis or thyroid storm is an acute situation where a person has uncontrolled hyperthyroidism. Now, they can develop this thyroid storm or this thyrotoxic crisis from infection or surgery, and it's life-threatening because they're going to develop hyperthermia, so they become too hot, tachycardia, and eventually heart failure and delirium. Toxic goiter will be present from hyperactivity of the thyroid gland, and it's caused by excessive stimulation by the thyroid stimulating hormone, which causes the gland to become larger in size. Exophthalmos is evident by the presence of protruding, staring eyeballs, a decrease in the blink and the eye movement, and it comes from increased tissue mass in the orbit, pushing the eyeball forward from increased sympathetic stimulation affecting the eyelids. If it goes untreated, it can cause damage to the optic nerve or the cornea. Okay, so the eyes will look buggy. Again, look at Wendy Williams. There's probably a picture of her in the news, like a facial shot like that, and you'll see the eyes. Hypothyroidism is common and easily treated by replacement of thyroid hormone. So we can do that with medications. Okay, hypothyroidism occurs in several forms, and it can be severe. So Hashimoto thyroiditis is going to destroy the thyroid gland. It's an autoimmune disorder, and it will eventually cause them to develop hypothyroidism. Myxedema is severe hypothyroidism in adults. And myxedema coma is acute hypothyroidism from hypotension, hypoglycemia, hypothermia, loss of consciousness, a life-threatening complication that happens in an undiagnosed or untreated elderly patient. So they'll have non-pitting edema, facial puffiness, and a thick tongue. I would know these terms, okay? Cretinism is untreated congenital hypothyroidism. So these kids are born with this. And it could be caused because of iodine deficiencies in pregnancy, or it could be because of a developmental defect. The thyroid gland may be non-functional or absent. We do neonatal screening for this because they can develop mental retardation or intellectual delay with the hypothyroidism. They could also die if it's severe. So in hypothyroidism, the goiter, if the cause is endemic, remember that's in a geographic area. A lot of people have it because they don't have enough iodine for their diet. They'll have an intolerance to cold, an increased BMI, meaning that they'll likely gain weight, lethargy and fatigue, decreased appetite, myxedema. A lot of times you'll see this in the older adult, okay? And this is if the hypothyroidism is left untreated or becomes severe. Symptoms: non-pitting edema in the face, thick tongue. If they go into the coma, they'll have hypotension, hypoglycemia, and hypothermia, leading to a life-threatening condition and loss of consciousness. So I would just know the differences, okay, between hypo and hyper. And with those immune disorders like Graves' disease and Hashimoto's, you want to know. Hashimoto's is going to cause hypothyroidism. Graves is going to cause hyperthyroidism. All right, next is the adrenal glands. So adrenal medulla, you can develop something called pheochromocytoma. It's a benign tumor, but it can lead to elevations in the blood pressure. Cushing's syndrome, where we have too much glucocorticoids being released. The mechanism for the excess amount of hormone is the effect on the related hormones, and it depends on the cause. So here you'll release excessive amounts of glucocorticoids. And in Addison's disease, you don't have enough adrenocortical secretion. Either the glucocorticoids, the mineralocorticoids, or the androgens can be affected, or all three. With pheochromocytoma, this is a tumor on the adrenal medulla, and it causes epinephrine, norepinephrine, to be secreted, therefore that increase in the blood pressure. Sometimes there's multiple tumors. It could be bilateral or unilateral, and it produces headache, heart palpitations, sweating, anxiety, elevated blood pressure. This can lead to a sudden high blood pressure episode and severe headache. Adrenal cortex. So Cushing's syndrome is caused by the release of too much glucocorticoids. Excess glucocorticoids may result from things like adrenal adenoma or tumor, pituitary adenoma or tumor, Cushing's disease, an ectopic carcinoma that results in paraneoplastic syndrome. So remember, that's when the tumor itself is releasing the hormones. Or iatrogenic conditions. So we gave iatrogenic is when it's caused by something else. So in this case, maybe you have a client that has cancer or a chronic inflammatory condition, and you're giving them corticosteroids all the time or steroids. This can cause an iatrogenic condition or Cushing's syndrome, because you're giving these excessive amounts of steroids. It can also be caused by substance abuse. So some of your athletes and stuff use a lot of steroids. So for Cushing's, what are they going to look like? Okay, a round face, like a moon face. And ruddy means it's going to be kind of red. Truncal obesity. So truncal is going to be like around the belly. And then they have fat pads between the scapulas. But their legs are going to be real skinny. So even though they have this big belly, their legs look real skinny. The hair is going to be thin, and they have something called striae, which is like little red streaks in the skin. So with Cushing's syndrome, we have what we call the moon or the round and puffy face. They'll call it the buffalo hump with those fat pads at the back of the neck or in the scapula. We'll have wasting of the muscles in the limbs. So that's what makes the legs and the arms so skinny, because of the muscle wasting. Fragile skin that has red streaks, which is your striae, and they can have hair growth known as hirsutism. Catabolic effects are going to be osteoporosis, decreased protein synthesis. This can cause delays in healing. And then they can have increased gluconeogenesis with insulin resistance, glucose intolerance, so they end up with diabetes mellitus. Other changes with Cushing's: retention of sodium and water. Okay, so that aldosterone, hyperaldosteronism here, because we're retaining too much sodium and water. Suppression of the immune system. Inflammatory response, atrophy of the tissue there. That puts them at risk for infection. Also, let me just go back to that sodium and water retention. So that can lead to high blood pressure or hypertension, edema, and also if the aldosterone is affected, hyperaldosteronism, not only are they they're retaining too much sodium and water, but for some reason here, they'll also retain too much potassium. I'll have to look at that and explain to you why, but they can have hyperkalemia. Atrophy of the lymphoid tissue, predisposing the client to infection. Stimulation of erythrocyte production. Emotional liability, meaning their emotions are all over the place. And they have this feeling of highness. Okay, my bad there. Now I know I didn't even have to go to the slide. So with aldosterone, it helps us retain sodium and water, right? Just give me 1 second here, guys. I want to put this on pause. All right, so you're also going to be releasing a lot of cortisol here. That cortisol is what's going to cause the increase in the potassium levels. So there's your picture of your person with Cushing's. Again, the belly's going to be bigger. The legs and the arms are going to be skinnier because of the muscle wasting. Okay, thin hair, that moon face, that ruddy complexion. We only have about 5 more slides, guys, so I want to just finish this out, okay? Healthcare professionals will have two concerns here, mostly the risk for infection and the decreased stress response in these patients, because the adrenal cortex here, if they have the iatrogenic Cushing's, the adrenal cortex can start to atrophy. So those are things that they worry about. All right, Addison's disease. This is the deficiency of the adrenocortical secretions. So we don't have enough glucocorticoids, mineralocorticoids, or androgens. Those are our steroids. The autoimmune reaction is the most common cause. The gland is destroyed by hemorrhage with some sort of infection. It could be meningococcal, it could be viral or histoplasmosis, but it destroys the adrenal gland. If y'all don't know, John Kennedy actually had Addison's disease. President John Kennedy. Okay, his adrenal glands were damaged. He didn't produce enough of the hormones, and that can lead to things like fatigue, digestive issues, and low blood pressure. So the problem is when your body's under stress, when you don't have enough of these, your body won't be able to respond to stress the same way normal people do. And it can kill you. So major effects of this are decreased blood glucose levels, poor stress response, fatigue, low blood pressure, weight loss, decreased appetite, hyperpigmentation, frequent infections. They'll have low sodium levels, a decreased blood volume, so that'll lead to low blood pressure. They'll also have high potassium levels because of the aldosterone deficit. They don't have enough aldosterone here, and so they can't excrete the potassium the way they're supposed to. That puts them at risk for cardiac arrhythmias and failure. Other manifestations are decreased hair because of the androgens, hyperpigmentation, so they'll have like a bronze color to their skin, creases in the skin, and mucosa, and the tongue will be affected because of the increased cortisol levels. I mean, the increased ACTH. Let me say that again. The mucosa and the tongue are also going to be affected because of the increased ACTH resulting from low cortisol secretion. So remember before I said ACTH helps us secrete cortisol. Here, because the ACTH levels are increased, we'll have low cortisol. If the ACTH levels decreased, then it would help you produce the cortisol. Questions on that? Everybody understand that? All right, so, I would know the basics about this. What's it going to look like and what's the cause of it? Okay, so for Addison's, you don't have enough steroids. In Cushing's, you have too many steroids. And then your signs and symptoms are on the slide here. Multiple endocrine neoplasm type 1. I really haven't seen them test on this. It doesn't mean they can't. Okay, this was previously known as Werner syndrome, and it's a rare genetic disorder caused by a gene mutation that affects the endocrine glands. MEN1 causes a tumor to develop in parathyroid glands, pituitary gland, and the pancreas. MEN1 can cause benign tumors in other endocrine glands, as well as adrenal glands, the lungs, the meninges, the skin, also digestive tract, stomach, and duodenum. You'll have multiple tumors in different areas at the same time. Most of them are non-cancerous, but they can cause enlargement of the glands and too many hormones. In some cases, it can cause a large tumor and cause the gland to lose its function and a hormone deficit. So they'll have two or more tumors in the endocrine or digestive tract. One is endocrine related, okay? and usually a first degree relative that has a similar tumor or a similar diagnosis. And then the gene mutation would be identified through genetic testing for that. And the last slide is just treatment for that. Again, I would briefly glance over that, but I really haven't seen any questions for that. All right, that's it. Any questions anybody has?